Okay, so in this section, we're going to get into the clinical management of migraines. So we talked about the clinical features of migraines, and let's talk about what we need to do. So I broke out this section into migraine assessment tools. We'll go over that first. Then we'll go over nutraceutical approaches to migraines, which is just like very basic things. What is the literature shown to help support migraines from supplement perspectives? Then we'll get into like general concepts of functional medicine approaches for migraines. And then we'll get into amplifiers of migraines from a functional medicine approach, and then activators of migraine. I'll explain what the difference between those two are. So let's start with migraine assessment tools. So we talked about previously using things like the MSQ questionnaire or the ID migraine questionnaire to have a validated tool to identify migraines, right? But the other key thing that you want to do once you make the diagnosis is before you start treatment is kind of get an idea of severity with a validated form, and also things associated with disability. And then you want to be able to see how frequently they are, right? At the end of the day, somewhere in your notes, when you're looking at migraines, you have to assess frequency of migraines and severity of migraines and duration. So for identifying migraine severity, one of the things that can be used is this MIDAS test. This is a disability questionnaire form of how migraines are impacting them. And then it's like 5 basic questions on how many days the last 3 months did you miss work or school because of your headaches, how many last months were your productivity at work reduced, and so forth. So you can read through the questions. And in the bottom is also A and B, which are just some general questions that are associated with the grading of the questionnaire, which are how many days in the last 3 months did you have a headache? On a scale of 0 to 10 on average, how painful were these headaches? These are, there's just some information there. But when you look at the first 5 questions, 1 through 5, they're kind of graded on a score. And it gives you a score between 0 to 5 with little or no disability, 6 to 10 with mild disability, 11 to 20 moderate disability, anything over 20 with severe disability. So if you're working with a patient who has migraine and their score was 40, and you go, hey, after a month of care, they're down to 28, even though they still have severe disability, they show some improvement. That's a good way to have an objective way to monitor migraines. Because remember, there's no lab test for migraines. There's no imaging studies for migraines. You're really looking at symptoms, and when you have these validated questionnaire forms, it can really give you a way to communicate. So that's something that's effective. Another way to look at migraines is a headache diary. So patients have migraines, you want them to fill out a diary. It's been working with practitioners before. They may have done these things, and some are like, I really don't want to do that again. Like, you got to get them to do it again. This is really important when you're looking at approach functional medicine, dietary and lifestyle strategies to see if things are changing. So this is a form, basically goes into headache diary, location of symptom severity, probable factors, any medications, things to use, hours slept, anything else before, mood before the headache, and so forth. And with the headache calendars, they also have these kinds where the remedy, the trigger, if they noticed anything. But nowadays, these forms are really obsolete because there's these great apps. So if you take just a few minutes and look at, any kind of app store and just type in migraine tracking, you're going to find all these different sources. And these can track, triggers. They can list down triggers. They can look at what days they had migraines, how severe the migraines were. They can list all that information, keep it there, and then they can email that directly to you, the practitioner, to get an idea of what it is. And they can keep these in electronic format from month to month. So if you're working with migraine patients in your practice on a regular basis, or would like to start to work with them, go ahead and download one of these migraine tracking apps, see how it works, and then have your patients use that as a way to communicate with you, and that'll be one of the best ways to track them. The most frustrating thing when it comes to migraine management care is, like, you don't know if you're getting any results with them. Because, if you ask a patient with headaches, do you feel any better on a day they have a headache? They'll say no, no matter what. They're not going to remember they're doing better one day or the next. They're just going to say, I feel terrible. You suck. I'm not getting any results. Why am I even here? Okay. But when you start to have something that's tracked over a month or over 2 months or 3 months, you start comparing it. That's when you start looking at it. So the good and bad day that you're having a consult with them doesn't really matter so much. So the key thing of first part of headache management is look at severity, look at frequency, look at duration, have that tracked by an app, and use that comparison over time. Okay. It's very, very rare you're going to do one thing and their migraines are going to completely resolve. Now, I've seen it happen with my own practice, but it's total luck and you have no idea what it is. Sometimes, we're going to get into nutraceuticals. I've had a couple cases where patients were magnesium deficient. Literally, as soon as we gave them magnesium, within a month, they no longer had migraines. That's very rare, but it can happen, right? Other times you're going to have to work through the case, so you want to see what's there. Okay. Well, we're going to start with nutraceutical approaches to migraines. So this is the bare minimum clinical skill. You're just going, what's in the literature? What have studies shown help with migraines? And what specifically do they help with migraines? And what can they do? So let me just start with saying this. There is absolutely no nutraceutical or herb that has been shown to completely eradicate migraines. None. Okay? There isn't. There is an exception with some people that are severely magnesium deficient, they get better. But with that minor exception, most of the time when people take magnesium with migraines, it doesn't cause complete resolution. What most nutraceuticals will do as we go over the research is they help with severity, they bring down severity, they help with the duration of the migraine, and they help with the frequency. Now, certain nutraceuticals are going to do different things. I made a chart for you at the very end of this section here, which tells you, are you dealing with the frequency issue, duration issue, severity issue, or all three? And what is the literature shown that can be effective for them, and the dosages, okay? So this is the basic minimum. You don't have any major skill in functional medicine. You're not trying to find root cause. You're not trying to go into deeper causes of comorbidities and wind down the web, but just some basic nutraceuticals, okay? So magnesium is one of them. Magnesium has been shown to have a major impact on migraine physiology and neurodegenerative diseases and this whole mitochondria, ATP, neuron function. There's 300 enzymes magnesium supports, and these pathways for migraines is one of them. And when you look at magnesium deficiency, they're actually quite common. So one of the things to understand with magnesium deficiency is, first of all, as people get older, their magnesium absorption levels go down significantly, okay? Second, if people are on things like diuretics, or they have diabetes or insulin resistant, or you start using alcohol, their magnesium absorption goes down. And then they have excessive sweating, they can have magnesium depletion. So it's not really uncommon to see magnesium levels that are low. Now, if you're ever looking at a blood test, if you see serum magnesium, that is not a marker for magnesium deficiency. You have to look at red blood cell magnesium, okay? And red blood cell magnesium is a specially ordered test that then will determine if someone has magnesium issues. But even many people you will see that are on the low normal end of red blood cell magnesium, when they take magnesium, has a tremendous impact on their migraines. So it may not just be attributable just to the level, because the level that may be reflected in the blood may not be reflective of what's in the cell. So just be aware of those factors. So magnesium should always be on the top of your list of nutraceutical when it comes to migraine management. This was a study that was published with 3,600 participants between 20 and 50 years old. It's a 4-year study. And the conclusion was, this was looking at their magnesium intake and their RDA levels, dietary magnesium intake. So those who achieved their magnesium RDA through diet and supplements had a 17% lower odds of reporting migraine than those who did not. Furthermore, adults in the highest quartile of magnesium consumption through diet had 20% lower odds of reporting migraine than those in the lowest consumption quartile. These findings suggest that inadequate magnesium consumption through the diet is associated with migraine in adults. Listen, magnesium you're going to find in leafy vegetables, lots of fruits. Those are going to be high sources of magnesium content, nuts, seeds, those types of healthy foods, not processed foods. So people that just don't consume enough magnesium, when they do the large-scale study, looking at dietary intake of magnesium and migraine, to see this relationship that's pretty significant there. This was another study that was done looking at serum magnesium levels in children with and without migraine. Looked at 35 subjects, 5 to 18 years old. The conclusion was they found statistically significant associations between low serum magnesium levels and the occurrence of migraines in adolescents, which may have treatment implications, which means potentially giving magnesium, right? So here we can see this illustration of what magnesium actually has been proposed to do when it comes to migraines. So you see magnesium, and then you see role of magnesium, and then physiological players of magnesium. So magnesium has a direct impact on the NMDA receptor. The NMDA receptor is one of the things that's involved with depolarization. So it's been shown to be a factor to make sure that this cortical spreading doesn't occur aggressively. So when magnesium levels are low, there's a much more intense cortical spreading. That's those neurons getting closer to the threshold and causing light sensitivity, sound sensitivity, fatigue of the brain, and so forth. Nitric oxide production is inhibited by magnesium level. Nitric oxide production is inhibited if magnesium levels are low. So endothelial nitric oxide helps with blood flow dynamics and health of the blood vessel, has antioxidant properties to protect the blood vessels against inflammation, helps modulate vascular tone blood flow, helps with pain processing. So magnesium is really critical for that pathway. Magnesium has been shown to impact serotonin-induced vasoconstriction. So you have platelets, which release serotonin in the vascular system, which is one of the mechanisms of migraine. Magnesium has been shown to have an impact on that. And then this CGRP level, which gets elevated with the trigeminal vascular system, that then promotes this whole, inflammatory hypoxic cascade in migraine. That's been shown to be decreased with magnesium levels. So you can see magnesium has far-reaching effects through multiple pathways for people that have migraine. Now, everything I showed you before was really studies showing people that don't get enough dietary magnesium, but then I want to go over studies where they actually used magnesium to see if it was effective for migraine. So this was a randomized controlled double-blind crossover study for 24 weeks with 63 subjects, and they were looking at the efficacy of magnesium oxide and sodium valproate in prevention of migraine. Now remember, sodium valproate is like a third-line therapy when the first line and second therapy migraine drugs are not working, and it's basically an anticonvulsant. It just basically calms down the brain, shuts down brain activity in a very simple sense. Impacts neurotransmission, so the whole brain calms down. This is to use when a patient has migraines, can't be controlled by regular medication, and they're going to be more drastic. Okay, so the study showed that 500 milligrams of magnesium oxide appears to be effective in migraine prophylaxis, similar to valproate sodium without significant adverse effects, and definitely much cheaper. Okay, so very effective there. This was another comparative study of sodium valproate and concurrent magnesium sodium valproate therapy and prevention of migraine headaches, randomized double-controlled double-blind trial. The obtained result of the study revealed that magnesium could enhance the anti-migraine property of sodium valproate in combination therapy and reduce required valproate dose for migraine prophylaxis. So you really, sodium valproate, which shuts down all brain activity, anticonvulsant, is something you don't want to take in high doses. So in this study, first of all, it showed that it helped with migraines, and furthermore, it reduced the dosage people that were on sodium valproate were taking to help with their migraine prophylaxis. And here you can see like these illustrations here with migraine attack, headache duration, headache severity, and painkillers, and magnesium is this dotted line here. So you can see magnesium is itself very effective at reducing headache duration and migraine attack, and it's not going to be as effective as sodium valproate, which is an anticonvulsant, which is, more effective, but still pretty effective. And then when used in combination together, you see the greatest effect, which is the solid dotted line, whether it's for pain or for headache severity. So it seems to be something very useful. When you look at all the studies that have been done on humans for magnesium dosages, you should know that the doses are between 500 to 2,250 milligrams a day. Okay? I really think you're better to go with the higher doses in the 2,000 range or for 2,000 milligrams or more per day. Okay? So the key features of magnesium for migraine. So studies have shown that if you don't have enough in your diet, that's been associated with increased migraine occurrence. Sufficient dietary intake of magnesium has been shown to reduce migraine occurrence. Low magnesium blood levels are associated with increased odds of migraine occurrence. But sometimes you won't see levels low in blood and it's still beneficial. And then doses are between 2,250 milligrams per day. So those are the key things with magnesium. So you should definitely consider magnesium in your protocol with migraine patients. Vitamin D is another major one. Magnesium, first of all, helps with intestinal absorption. Vitamin D is another one. Vitamin D definitely helps with intestinal absorption of magnesium, which is really critical. It's been shown to support neurotropic factors, dampen microglial inflammation, modulate neurotransmitters, And when they've done studies on migraine and vitamin D, they found some beneficial effects. This was a meta-analysis of 2 randomized clinical trials, 10 observational studies, and the conclusion was that serum 25-hydroxyvitamin D levels was significantly lower in migrainers than non-migrainers. And hypovitaminosis D, being vitamin D levels that are deficient, vitamin D levels below 30, was significantly associated with migraine. Overall, vitamin D supplementation significantly reduced migraine frequency, but not its duration and severity. So vitamin D reduces frequency, but doesn't change severity or how long the migraine attacks are, according to meta-analysis of all the significantly human published studies. Okay, now CoQ10 and migraine. CoQ10 has its impact directly on the mitochondria, which is part of the dysfunctional web of migraine that then causes this cortical spreading phenomenon to take place. CoQ10 also dampens the microglia, which is involved with the neuroinflammatory response. It also dampens vascular inflammation. So those are all mechanisms where it can be very helpful for migraine attack. This was a study, meta-analysis. And again, for me, whenever I try to cite studies, I find it best to put meta-analysis, which is a combination of all the studies published, the random clinical trials published together, so it's not cherry picking. Okay, so they do a composite score of all the findings from these other studies and determine what the conclusion is when they look at the composite of the research that's been out there. Okay, so this was 5 RCT, 5 randomized clinical trials, 34 subjects, 104 milligrams of CoQ10 per day. They found that there's no difference in migraine severity with CoQ10 and placebo, but pooling data provided consistent results with previous findings regarding the effects of the CoQ10 at reducing migraine duration and migraine days per month, or so frequency. So the duration and frequency went down, but not the severity. This was another study in CoQ10. Basically, it showed that reduced duration of headache attacks is the main thing, but not severity. Then, if we look at other nutraceuticals, riboflavin is another one that's been published a lot on migraine. This is a study of 8 randomized clinical trials, 673 subjects, and they found that B2 riboflavin at 400 milligrams a day for 3 months has significant effects on days, duration, frequency, and pain scores of migraine attacks. It really seemed to have an effect on all 3. Alpha-lipoic acid is another beneficial supplement. This was a double-blind, placebo-controlled, parallel design study with 92 women, 300 milligrams a day for 12 weeks. Results showed that 3 months of alpha-lipoic acid supplementation in women with episodic migraine led to significant reduction in migraine symptoms, including severity and frequency. And then essential fatty acids. There's 40 randomized clinical trials on essential fatty acids. So network meta-analysis suggests that prophylactic EPA, DHA, like fish oils, supplements are associated with better reduction of the frequency and severity of migraine episodes and ferric susceptibility. In addition, these beneficial effects were not inferior to those of concurrent pharmacology regimens that provide FDA treatment. So fatty acids are very, very effective for them. The key thing with essential fatty acids is they immediately cross the blood-brain barrier. They go into the trigeminal vascular system very, very quickly. They have a very powerful anti-inflammatory effect. They immediately impact prostaglandins that are involved with vascular dynamics associated with migraines. So here's an illustration of them, like showing what they do. They block inflammation. They change BDNF levels. They block the pain pathways and so forth. Melatonin was studied in 5 randomized clinical trials and looked at in this meta-analysis. And melatonin therapy and migraine associated with reduced migraine attack frequency, duration, and severity over placebo. So seemed to impact all 3 of those. This was another study that was done, double randomized clinical trial, and it also showed that melatonin decreased frequency, duration of migraine attacks, and reduced migraine disability and improved quality of sleep. So it seems to be very effective here. You can see here melatonin compared to a placebo for attack frequency, much better with people that were taking melatonin. Attack duration, much better with people taking melatonin. Pain severity, a slight change, slight difference, but only after 2 months. And then you can see here, number of analgesics, like the pain reduction, pain relief benefit was much greater with melatonin. Now, key thing to look at here with this is reflective of many other studies, is if you look at their effects on the first month, there isn't much change. There's certainly not going to be any change when someone takes melatonin, like during a migraine attack. It's not going to do anything. It's not because of any benefits, even after the first week. So what you can see with this illustration of melatonin, also with the other nutraceuticals, it takes some time for these nutraceuticals to have an effect. This is going to be really, really important for you to share with your patient. Your patient has to have this awareness of these things. So when we look at nutraceuticals and botanicals, there is an effect. Now, when we look at botanicals, there really isn't much good research on it. There's some potential effects of like feverfew having some positive results, but very limited. Same with butterbur, but nothing dramatic. Nothing like what you see with magnesium or melatonin or some of the other nutrients. Okay. Now this is based on research. Obviously, there's going to be some individual patients that may have tremendous response to one thing compared to another person, of individual uniqueness, but for the most part, not the best research of botanicals. So here's a couple important key concepts. So nutraceuticals help reduce frequency, duration, and severity of migraines when taken prophylactic for 4 to 12 weeks. So they have to be taken for at least a month. So if you don't know this as a practitioner and you go, I'm going to give my patient these supplements because I read they're good, and they take them for like the first month and notice anything, they go, it's not working. If you didn't explain that to the patient at the very beginning, they're just going to think you don't know what you're doing. You got to make it very clear. Research is showing that they're not really having much of an effect the first month, most of these nutraceuticals, and it really takes, somewhere between 3 to 4 months, probably around the third or fourth month, to really have a noticeable effect. Some will affect the severity, some will affect the frequency, some will affect the duration. It really depends. And there's not really an effective nutraceutical to take that's going to really help in an acute migraine attack. Okay? This is the summary of all the research I showed you, all these different meta-analyses compiled together. And you can look at this of going, so if you're looking at a patient, looking at a nutraceutical approach to reduce their frequency, these are the options, or maybe this whole thing as a protocol could be something that they consider taking. And then like many of these things in frequency also overlap with duration. It's basically CoQ10, riboflavin, melatonin, and with severity, it's like fatty acids, riboflavin, alpha lipoic acid, melatonin. So, you can use a protocol for all of them to help with frequency, duration, and severity. Some people, main issue is just severity. It's not really the frequency. You may just want to focus on things for severity, but again, these are taken for 4 to 12 weeks. They're not really effective during an acute attack. So that's the main takeaway from nutraceuticals. Now, if you take a look at the vicious web of migraine pathophysiology, this is where all these different nutraceuticals are having an impact. Like the magnesium impacts the release of CGRP, vitamin D and omega-3 help with vascular inflammation. Melatonin is a key factor in microglial activation during inflammation. So is omega-3 with neuroinflammation. Magnesium is really critical for this ATP pathway for mitochondrial function through the NMDA receptor. CoQ10 has been shown to be very helpful for non-ATP production. Same with the riboflavin. So nutraceuticals are one line of approach. They're the least effective. Okay? They're going to have some effect with some people for a period of time after, let's say, 3 to 4 months, but it's not going to be enough. The biggest mistake people make with nutraceuticals is they think they're going to be helpful during an acute attack, which they're not, and they think they're going to be helpful as soon as they start taking them, and they won't. Okay? So remember, 3 to 4 months is what is the minimum to start seeing some changes. And if you're not tracking them with the app to look at frequency, duration, severity, you may not even know it as having any real effect. Okay? And then at the end of the day, as a clinician, all you can really do is like educate the patient with what you know. Like, hey, these are the supplements that have been shown to help with frequency, duration, and severity. This is the list. It's not going to work for at least 3 to 4 months. I don't know how much of an impact it's going to have on you. You're going to, if you want to commit to this, commit for 3 to 4 months, then see how they make you feel. If they're helping you and it's worth it to you, continue. If it's not helping you, stop. But this is the nutraceutical option. It's like what do supplements have been shown to do for migraines? Now, in a functional medicine approach, we got to dig deeper. We got to try to untangle the web, because for many people, nutraceutical approaches directly published for migraine prophylaxis won't be enough. Okay, you're gonna have to dig a little bit deeper. And I should also say, for some people, it's gonna have a dramatic impact. So it's really gonna depend on the patient population you serve. So you're not gonna know until you try and see what happens. Okay. So remember, the goal in a functional medicine approach is you have this vicious cycle. And if this vicious cycle gets wound up, it's then going to lead into high frequency episodic patterns and into chronic. And this is where you have most significant disability. And the people that don't respond to medications end up in this way. And they have this vicious cycle really active, or they have ongoing triggers that promote this vicious cycle as part of their pathophysiology. Now, you should know that there's an allostatic load that's involved with these things too, these triggers. So here you see an example of, like, let's say here's a migraine threshold that can cause the genes to, let's say someone has genetic susceptibility to migraines, they have this calcitonin gene-related peptide polymorphism. So they have far-reaching effects of it when it's released compared to other people. And the fact that they have this gene variant is what's causing them to have migraines compared to other people. And for them, even though they had some genetic susceptibility, and they have some magnesium deficiency and some insulin resistance, which have all been shown to be potential triggers of this trigeminal vascular pathway, they don't really reach thresholds, they don't have migraine. But once they start having hormone imbalances and their asthma starts to flare up, that's when their asthma level starts to pop out. And now, as a clinician, you're going back, well, how do I get them under this migraine threshold? What kind of variables can I do? What can we do for their asthma? What can we do for their insulin resistance? Can we start giving them magnesium? And what you're trying to do is get them below this migraine threshold, so you can find a way to either eradicate their migraine or make it more or less severe, or reduce these things that are really driving that trigeminal vascular inflammatory pathway. Now here you see an example of someone who's got like some variables here, again, starting with gene susceptibility. They may have here at this point, they don't have a migraine. They haven't reached threshold yet. Once they reach threshold, get past this, they end up with a migraine. But you should know that it's not just with these variables, that these variables are also weighted. For some people, hormone imbalances could have much more weight getting them to threshold. So it's going to have much more reaching effect. So for like males that have very low testosterone, that could have a significant effect for them. Like as soon as they get their testosterone levels resolved, that can put them under the edge of migraine threshold. Or it could be a female that has estrogen fluctuations because they have PCOS, and they get their PCOS under control. And magnesium may not have that key of a significance for them, but for other people, magnesium could be weighted much more, and it has a tremendous impact. So you have to realize that each of these variables are weighted differently. For some people, insulin resistance may have a lot of weight, much more weight than magnesium deficiency, for example. So those are the things you want to think about. You're trying to figure out what variables are there, how do you get them off threshold when you're going past the nutraceutical approach, okay? Now, as we go into this functional medicine approach, you want to look at what are amplifiers. So what I refer to as amplifiers of the web are things that cause this vicious cycle with microglial neuroinflammation or vascular inflammation or mitochondrial dysfunction. And the activators of the web are going to be things like comorbidities, okay? So those are going to be things like hormonal dysregulation, obesity, insulin resistance, lower respiratory tract infections, gastrointestinal conditions, general inflammatory conditions. And basically, when you're looking at this amplifiers of the physiological web, we're talking about things that wind this up. So the more wound up the migraine physiological web is from pre-existing amplifiers such as vascular inflammation, mitochondrial dysfunction, microglial neuroinflammation, the less it takes for activators to trigger a migraine to progress to chronic migraine. So here is the list, for example, of activators. Here's the web. So these activators on one side, which we're not going to talk about, and then amplifiers. So the amplifiers are vascular inflammation, and we call them amplifiers because they keep feeding back to the trigeminal vascular system and promoting the migraine pathophysiology. So vascular inflammation is a key factor. Neuroinflammation keeps feeding back to the trigeminal vascular system, and then mitochondrial dysfunction keeps feeding back to the trigeminal vascular system. With any kind of chronic disease, in many cases you're dealing with a vicious cycle you have to break. So these are amplifiers, and then these are activators. When it comes to functional medicine management, you want to look at amplifiers and you want to look at activators. We're going to just first talk about amplifiers. So vascular inflammation creates this vicious cycle. Neuroinflammation creates its own vicious cycle. And then mitochondrial dysfunction creates this vicious cycle. The more wound up this is, the more likely that they're going to head in towards a chronic migraine pattern. Now, let's first talk about vascular inflammation, okay? So, when the trigeminal vascular system gets activated, it causes this neurogenic inflammatory pathway in blood vessels, this neurogenic inflammation pathway. So neurons stimulate neuropeptide releases, and it activates circulating mast cells in the blood to then cause inflammation that then starts to damage and impact vasodilation and smooth muscle activity of the blood vessel itself. But there's inflammation and injury to the blood vessel that's caused by neuronal activation, hence the name neurogenic inflammation. Neurons themselves are activating it. So one of the features of migraine that we talked about is that this trigeminal vascular system gets activated, and the neurons from these branches then promote vascular inflammation. Okay? So key concept. The more pre-existing vascular inflammation that occurs in the cerebrovascular system, the more prone an individual is to migraine. So if you look at research on this, for example, with homocysteine, they found some of these relationships. This is a paper published called Homocysteine and Migraine, a Narrative Review, and they go on to say that evidence from interventional studies in which treatment of hyperhomocysteinemia, so homocysteine levels above 15, with folic acid or vitamin B supplementation was effective to lower plasma homocysteine below 15 and decrease frequency and severity of migraine. So we have these, this is a narrative review of many publications that are in the literature. But homocysteine itself has been shown to be a major inflammatory mediator in blood vessels, and it's part of the migraine pathophysiology. So homocysteine directly itself causes a vicious cycle promoting more neurogenic inflammation. It shuts down the NMDA receptor, which uncouples the mitochondria, inhibits GABA A receptors, which then cause greater cortical spreading, and then it causes oxidative stress, which further uncouples the mitochondria, which then promotes more cortical spreading. So homocysteine levels that are high before with someone who's got susceptibility for migraines can be a big issue. So as you're trying to untangle a web in a functional medicine model, you definitely want to check things like like homocysteine, and see if they're elevated. Now, listen, lab ranges are 15, but anything above 10, you really should suspect as potentially being a problem. So you should also consider with people that have migraines and high homocysteine, if they have an MTHFR gene type, you can measure those with any standard lab. See if they have a SNP, single nucleotide polymorphism for them, and then basically you want to focus on lowering their homocysteine levels. Here's another illustration of how homocysteine is causing some of the vascular mechanisms of migraine. And ultimately, the goal is to give them methyl donors like B12 and folate to transfer those methyl groups, so homocysteine can break down into cysteine and cysteine and so forth, right? B6, B12, folic acid, and so forth, are the main mediators. Now, I got to tell you, there's more than homocysteine for vascular inflammation. And this is just leading me to, if you wanted to dig deeper into this mechanism of migraine, one of the courses that I put together was the neurovascular course, Clinical Strategies and Treatment Applications. And just to give you an idea, these are all the different mediators for inflammation in blood vessels besides homocysteine. So ferritin is really critical. TMAO levels are very critical. Oxidized LDL, MMP9, these are all really critical. The prostaglandin levels are very critical. These are all things that also cause neuroinflammation. So I don't have the time in this course to go into a deeper thing for vascular inflammation. Just have you be aware of homocysteine, which is a very important one and a very easy one to make applications to. But if you have interest in going deeper with this, go into this course. You'll learn about all these inflammatory pathways and all the different steps associated with vascular inflammation. I'll take you through the step-by-step process of how to go through history, physical exam, lab test, specific cardiac evaluation, and functional medicine profiles to address that. But vascular inflammation is something you definitely want to be aware of. Now, let's move on from vascular inflammation to neuroinflammation. So within the brain itself, we have glial cells called microglia, and they get activated from this trigeminal vascular activation. Like neuropeptides like CGRP turn on these microglial cells and they create an inflammatory cascade. The inflammatory cascade then causes inflammation throughout the brain, which then further activates the trigeminal vascular system, causing this vicious cycle of inflammation. So here you can see an illustration of the pathophysiology of migraine, and you can see these microglial cells get activated. So here you can see the trigeminal vascular system has certain sensory nerve endings. They release things like CGRP into the bloodstream. You can see like yellow and different mediators, neuropeptides being released in the bloodstream. They turn on microglia. You can see this microglia changes shape, becomes activated, and creates inflammation in neurons, and this perpetuates cortical spreading and the pathophysiology of migraine. So dampening this microglial system becomes really, really critical. Now, microglia have a pro-inflammatory state for like pathogen elimination, tissue issues, and neuroinflammation. And then they have let me go back. They have an anti-inflammatory steroid for resolution, inflammation, and healing. So what happens with the CGRP and neuropeptides that are activated through the trigeminal vascular system is this microglia shift into this M1 pro-inflammatory state. The same thing that happens with head injury, same thing that happens with infections. And once they shift into this stage, other things that keep these microglial cells activated ongoing will be things like insulin surges, smoking, inflammatory bowel conditions, pro-inflammatory diet, anything that causes hypoxia or like with things subtle as like being anemic, previous brain trauma that can activate these cells, vascular inflammation like we already talked about, depletion of antioxidant reserves, then it can keep these M1 states and this microglial active, which then perpetuates this migraine pathophysiology. So key concept. Clinical variables that shift microglia into M1 pro-inflammatory state increase susceptibility to migraine. So these things here. And if you look at these things here, they also have a direct link to comorbidities, which we'll talk about a little bit later, but you got to get this microglial cell pathway dampened, okay? Now, key concept. Individuals with traumatic brain injury or chronic microglial activation can develop prime glial cells and have exaggerated neuroinflammatory responses in the brain with trivial triggers. There are some people you have to be very aware of that they get infection in their brain or they get a migraine and their microglial cells convert into what's called a prime glial cell. They lose their ramified structure with all these legs, then these branches that allow them to move around, and they become ambioid, so they get stuck in one area and they get stuck in an M1 pro-inflammatory state. And it takes very little inflammation to then cause them to be triggered. So like an inflammatory diet. So someone, for example, has prime glial cells in their brain, if they have exposure to an inflammatory dietary protein, they may have significant reactions that are much more than the person who gets exposed to dietary protein doesn't have any, dramatic inflammatory reactions. This is an important area of study that, again, you may want to dive further into. We go into this in the neuroinflammation course, the cross-institute course I put together. And in that course, I go through how to figure out neuroinflammation through medical history, initial exam, labs, and imaging, and all so forth. But the key things you can take away and then we'll go also into testing, but the key things you can take away from it, first of all, diet. Basically, insulin triggers this neuroinflammatory process, and drops in blood sugar. Ideal thing to dampen neuroinflammation is literally to put someone in a low carbohydrate diet with blood sugar stability. And even better would be to put them on a ketogenic diet, have them go into ketosis, because ketones have been shown to dramatically churn off inflammation in the brain. Like the actual ketone bodies dampen glial activation of producing M1 expression of pro-inflammatory chemicals. In addition to that, once glial cells get primed, the only thing that's been shown to really clear that debris of these primed overactive glial cells is fasting. Now, this has been done in animal models, but we're never going to be able to do human studies because we're not going to be able to dissect human brains out to see microglial cells. So we hopefully have to conclude from that. So managing insulin, getting them into a ketogenic state, getting them to intermittent fast can be really important, especially if you think that their brain is severely inflamed. Now, when people have severe brain inflammation, have brain fog, they can't think clearly, there's this past history of traumatic brain injury. So those would be clues to, as a clinician, dive into this neuroinflammatory pathway more. For some patients that have migraines, you may do that. For other patients, that may not be as critical of a thing for them. So you're going to have to determine that as a clinician. And then there's also nutraceuticals that dampen neuroinflammation. And when you look at these flavonoids here, these polyphenols like resveratrol, curcumin, apigenin, luteolin, these are very effective for neuroinflammation because they can actually cross the blood-brain barrier and dampen neuroinflammation. Not all anti-inflammatories can. Fish oils are very effective. Short-chain fatty acids, butyrate propionate can be very effective. Glutathione can be very effective, but there's definitely a clinical goal to dampen neuroinflammation. Okay. So to go deeper, check out the course at the very basic level. To dampen microglial inflammation, use things like resveratrol, curcumin, make sure they don't have insulin spikes. If anything, to see how they feel on a ketogenic diet. Go from there. Okay. Now, if we move on from this neuroinflammation pathway, we can get into this neuron mitochondrial dysfunction pathway here. And with this neuron mitochondrial dysfunction pathway, what we can see is, let's go back. We can see that it lowers neuron ATP. And when there's less neuron ATP, then there's inability to activate the sodium potassium, to push sodium out of the cell, the neuron. So the resting memory potential gets closer to threshold, and those neurons just fire on their own. That's where you get light sensitivity, sound sensitivity, odor sensitivity, all the things that go along with the depolarized state or that cortical spreading of migraine. So this whole cortical spreading issue is really going to start with dysfunction in the neuron mitochondria, which neuroinflammation and vascular inflammation themselves promote. But supporting the mitochondria can be very helpful. And in one part of supporting the mitochondria is just reducing brain inflammation, because microglial activation and inflammatory response we just talked about uncouple the mitochondrial pathways, so it's less efficient making ATP, and as ATP gets lowered, there is neurons close to threshold, activation with minimal stimuli that occurs, and then neuron endurance goes down, so the brain fatigues very quickly. Okay, and then studies that have looked at special nuclear magnetic resonance studies to look at migraineurs have clearly found like their mitochondrial functions are not working, they have significant brain deficits, and you can, the key thing with this whole migraine thing is that this mitochondrial pathway is so critical to stopping hyperexcitability. So once mitochondrial levels are depleted, there's an effect on this NMDA receptor where neurons get close to threshold, and then you get the aura symptoms and migraine overactive symptoms and cortical spreading and so forth. They've also found things like iron, which is really critical for supporting the mitochondria and iron deficiency anemias. Remember, anemias are critical because red blood cells carry oxygen to the mitochondria for them to make ATP. So when someone has low iron levels or you're anemic, that's been shown to help with reducing frequency and intensity of migraines. But there's a whole list of nutraceuticals that are very supportive for the mitochondria. And for some people that have migraines, you may want to go down this pathway. Now, let me explain a couple things really quickly here. You're going to have to work through a migraine patient. Like for some people, you're going to focus on neuroinflammation first because they had a past brain history, and so forth. For other people, you're going to start with neurovascular inflammation, be really aggressive with that because you just see their homocysteine levels are really high, right? You're not going to necessarily do everything at once. You're going to have to look at this as a strategy over time. And then you're going to go after certain pathways and go, hey, listen, what I really want to do is go after this microglial activation for the next month. Let's try to see if we get you in ketosis. Let's see what happens to your migraines when we do that. Let's happen to the frequency, duration, severity. Let's put you in a bunch of anti-inflammatory microglial compounds. And let's see what happens to your migraine tracker in the next 4 weeks, 6 weeks. If you're doing better, let's continue on and push that pathway a little bit more, because this is one of the main mechanisms that promote migraine. So let's focus on that. You may not do don't try to do everything at once. Like, as a matter of fact, if you try to do everything at once and the patient gets better, you're not going to be able to find out which pathway you need to really focus on and push. Okay? For example, someone that comes in and has migraine, and let's say we tried the nutraceutical protocol with magnesium and all these different nutraceuticals first, and helped a little bit, but nothing life-changing. So can we do more? Of course. So then you go and check their homocysteine and vascular inflammation. Maybe it's not a big issue. And then maybe you go into this microglial activation or inflammatory pathway and go, oh, you've had some head trauma. Let's see if this is a pathway that could be involved. And you start to, going through the whole ketosis thing, and they immediately start to feel significant difference in their function, energy, their migraine intensity goes down, the severity goes down. You do that for the second month, it keeps getting better, and then you go, okay, this is my pathway. So then you're like, okay, well now let's do some prolonged fasting, get rid of these prime glial cells, right? That may be one of the things you may do. Let's do some IV NAD therapy to see if we can get some changes to your brain inflammation and mitochondrial function. So that's how it works. That's a process. And you have to have this constant communication with your patient, educating them what pathways are involved. They can use. This is why also in all the courses that I put together, I always give you all the major diagrams so you can use them for patient education. So you always see a link to diagrams. The diagrams are showing the PowerPoints. You can print those out and use them with your patients to explain things for them. Okay? And if the patient understands the web, the amplifiers, and what your goal is, you get better compliance and then become a better communicator to tell you what needs to be done. Okay. Now, let's go back to the mitochondria. Sometimes you just want to push things to support the mitochondria, and you want to go after this mitochondrial pathway because they have a lot of depolarization, lots of aura, lots of light sound sensitivity, neurons are close to threshold. And again, if you want to learn more about this pathway in greater depth, I can't teach you in this course. About the mitochondria, there's a course I put together, Chronic Fatigue and Pain Syndromes, and we go into all the main pathways we know about how to manipulate the mitochondria with diet, nutrition, lifestyle. These are the different nutraceuticals that impact different parts of bioenergetics. Again, I don't have time to get into all these for this course, but this may be an area you really push when it goes into improving someone's migraine vicious cycle web. Okay, these are things that impact things like mitochondrial biogenesis, making mitochondria, mitochondrial fusion, where mitochondria bind together, mitochondrial mitophagy, where you get rid of dead, inefficient mitochondria, and so forth. Okay, and of course we go through a step-by-step process, labs, questionnaires, medical history, and then a strategy of how to try to make these changes in mitochondrial function. But for this course, the key thing is that you're aware of amplifiers of the migraine physiological web or microglia inflammation, vascular inflammation, mitochondrial dysfunction. So the key concept here is the more wound up the migraine physiological web is from pre-existing amplifiers, such as vascular inflammation, mitochondrial dysfunction, microglia neuroinflammation, the less it takes for activators to trigger a migraine to progress to chronic migraine. So that's the goal. And the key thing you're going to be looking at is frequency, and then severity and duration. Okay? Now, those were all related to amplifiers, but remember, when we look at the web of migraines, we also have activators. So let's get into that. The more activators or comorbidities a person has, the more likely they are to wind up the migraine physiological web and develop chronic migraines. So remember, the comorbidities, we talked about them earlier, but they're really inflammatory-based conditions. If you break down the comorbidities, you basically get like hormone dysregulation as a category, obesity, insulin resistance, metabolic syndrome, diabetes as a category, upper and lower respiratory conditions as a category, GI conditions as a category, and just general inflammatory conditions. These are all activators. I will tell you, you're going to have a lot of profound impacts with amplifiers in combination with activators when it comes to treatment. And again, because this is a layered effect. You may be going after different things at different times based on the patient's history and presentation. So a question like that may come up with people hearing this for the first time. They're like, well, when would you go into obesity, insulin resistance versus diabetes versus GI? What do they come in with? Are they pre-diabetic? Is their chief complaint GI disorders? Is their chief complaint hormonal? Like whatever symptoms they come in, like if you see a patient's history and you do a workup and they have migraines, whatever is popping up on this list that's more obvious to you, that's where you want to start. If someone has, chronic upper respiratory tract infections and allergies and has chronic migraines, but they're not dealing with insulin resistance and obesity and diabetes, you probably should start with the respiratory sinus stuff and see if that can impact their migraine. So we talked about the web before. Now we're going to talk about these activators, okay, which are these activators here on this list. Let's talk about hormone dysregulation. Basically, these are all linked to migraines. So let's talk about hypothyroidism first. lots of link with hypothyroid patterns that impact energy dynamics in the brain and vascular dynamics that lead to migraines. And this was a study of RCT showing basically migraine reduction when people had subclinical hypothyroidism and they were given thyroid replacement. And, this is another study showing that level of neuroinflammation was generally reduced when they started doing thyroid treatment. Now, there's some strong relationships between actually Hashimoto's being, the autoimmune response against the thyroid gland with positive TPO thyroglobulin antibodies as a key factor in promoting the ongoing trigger of trigeminal vascular pathophysiology of migraine and in promotion of quantification. So one of the things you may want to dig deeper into, if your patient has chronic migraines and they also have hypothyroidism, check their TPO thyroglobulin, see if they have Hashimoto's, and then learn how to treat Hashimoto's. If you don't know how to go over Hashimoto's, I put together a 12-hour course on it. We talk about the Hashimoto's vicious cycle web. We talk about all the triggers of the web. I give you a checklist to make sure you don't miss anything when it comes to going through all the things we know about treating Hashimoto's in the literature. And basically, go through the content, go through the steps, and have a really good strategy to work through a patient with Hashimoto's using the functional medicine approach. Now, another key factor that's linked to migraines besides hypothyroidism is androgen deficiency in males. And it listed some studies for you that shows these relationships between androgen deficiency in men and migraines. There's many more in your course material notes, but again, we don't have time to go over how to manage male hormone deficiency patterns. There's a course I put together called Hormone Imbalance Throughout the Lifespan, and we go through all the main patterns. These are all the main types of patterns that can cause low testosterone related patterns, low androgen dominance patterns, low androgen function symptoms. These may be related to migraine, especially primary and secondary hypogonadism. So if you're not familiar with that, you may want to check that out. Menstrual cycle irregularities are definitely linked to migraines. So, again, we don't have time to go over this, but in our hormone course, we go over, all the steps you need for normal menstrual cycle function, all the ways that menstrual cycle regulation can take place, and then clinical strategies. The same thing can be said about perimenopause. Perimenopausal hormonal shifts can lead to migraines. We'll talk a little bit about this more tomorrow. We talk about menstrual headaches. But drops of estrogen have been shown to not only cause hot flashes, but they create a neuroinflammatory response, which then fires up the whole migraine pathway. So if you need more information there, you can look in that. And then in that course, we also talk about ways to strategize perimenopause from a functional medicine approach. Now, in addition to hormone imbalances, obesity, insulin resistance, and metabolic syndrome, they've all been shown to be a trigger for migraines. Basically, you're looking at blood sugar disorders. And there's two main types of dysglycemia or blood sugar disorders, hypoglycemia and insulin resistance. So studies show when people that have migraine susceptibility have their blood sugar drop, they become hypoglycemic. That impacts their ATP levels. That can be a major trigger or promoter for migraine. You can check out this paper that's in your course notes.
Yep.
Insulin and migraine. Insulin is also itself, insulin surges have been shown to be linked to migraine. So when people start to get insulin resistance, they seem to have greater episodes of migraines and switch into chronic. And remember, there's peripheral insulin resistance as receptors, but there's central insulin resistance, which is the brain's ability to carry glucose across with insulin receptors. So as people start to develop peripheral insulin resistance, they also develop central insulin resistance. And as this central and peripheral insulin resistance gets worse, they start to surge out more insulin. They get hyperinsulinemia. Those have been shown to be major migraine triggers. In addition to insulin, they found that body fat itself releases things like adipectin, leptin, different lipid peptides that are very inflammatory, and those can be factors that also impact migraine and cardiovascular risk. So, again, I don't have time to go over all the strategies we talk about for insulin resistance diabetes, but we do have a course. Obviously, many of you that do functional medicine already have a lot of experience with that. Another key thing that's been shown is upper and lower respiratory are key factors that trigger migraines. So if you look at the study here, where they look at comorbidities, asthma, bronchitis, emphysema, sinusitis, allergies, hay fever, they all seem to have a promoting factor of triggering on that trigeminal vascular inflammatory pathway, whether it's upper or lower respiratory. And some of these upper respiratory pathways, like here you can see sinus inflammation. So pathways, neurological neurons from the, here they show the superior sagittal sinus, directly go into the trigeminal vascular system, because it's part of the face, and all things face and head go into the trigeminal vascular system. And they directly turn on the trigeminal vascular pathway associated with migraine and cause release of CPAG, calcitonin gene-related peptide. Now, remember, not everyone that has sinuses doesn't have migraines, but one of the key features of migraines is these people that have migraine or migraineurs most likely have a gene uniqueness in their release or receptor response or activation of the CGRP or other neuropeptides that makes them very susceptible when these things happen. So when a person that has this gene susceptibility has their active inflamed sinuses turn on this inflammatory pathway through the trigeminal vascular system, could be a key contributing factor to their chronic migraine developments. We don't have time to go over how to treat upper and lower respiratory conditions in this migraine course, but you can do a deep dive in it with our respiratory and sinus condition course. And then we go into all the different upper and lower respiratory patterns. We go into physical exam, we go into treatment, we go over all the clinical skills you need to understand how to manage upper and lower respiratory system pathophysiology. We talk about what things are critical for pulmonary resiliency. We talk about nutraceuticals for each of these pathways. We talk about adjunctive therapies like nasal irrigation, nasal sprays, nebulizers, humidifiers. These things can all be important for a migrainer that has upper respiratory issues. We talk about how important it is to improve their air quality in their home to really dampen this. And this can be a key factor for migraineurs that have chronic allergies and sinuses and so forth. Now, another key activator of this migraine pathophysiological web has been shown to be GI disorders. There's numerous studies that have shown this gut-brain axis. This is one of them that looked at things like H. pylori infections, IBS, and celiac disease. And the bottom line is there's an inflammatory pathway from the gut that directly turns on the trigeminal vascular system. And there, this concept of gut on fire, brain on fire. And when things like intestinal permeability and dysbiosis are occurring, these things create inflammation, and input is taken directly through the vagus nerve of the gut into the brainstem to then activate the trigeminal vascular system, which then releases things like CGRP and then promotes cortical spreading. And here you can see an illustration of like GI disorders causing pro-inflammation, elevated CGRP, disruption of serotonin cycling, but the key factor here is the GI disorder. So when you're looking at someone who's got chronic migraines, you obviously want to make sure they don't have any types of chronic gut inflammation or gut infections. We don't have time to go into that in this course. But in the GI clinical strategy and treatment application, we spent 12 hours. We talk about a north to south model of treating the gut. And that could be something, if you're not familiar with, to get more information on. And then lastly, the main other activator of the migraine web are general inflammatory conditions. Sometimes you just need to block inflammation from as many ways as you can. And the key thing I find is everyone knows inflammation is important, but not many people really understand inflammation. So one of the things we did is we created a course on chronic inflammation and treatment applications. And we go through all the different pathways of inflammation, and we talk about the pathways of inflammation activation, inflammation recruitment, inflammation amplification, and then things that cause inflammation resolution, and what can go wrong and how to support these pathways. And we talk about things like exogenous triggers and pre-existing inflammation, and then how those things combine together to cause severity and duration of inflammation. And we go over a checklist of the most common things that do that. And that can be very important for some of your migraine patients as well. So ultimately, when we look at the clinical management of migraine, we have reducing the amplifying web, which is microglial nerve inflammation, vascular inflammation, mitochondrial dysfunction. And then you want to try to find which of these main activators are involved with your patient's history, and then try to resolve those. And on top of that, you can use some of the nutraceuticals that have been shown in literature to impact with severity and duration. Remember, treating migraines is really like peeling back, layers of the onion. You really want to, think about this as a thing you do over time. Your patient needs to really understand that principle. for this section, especially on migraines. These other adjunctive courses are really important. And, when I first put together the Crohn's Institute, it took me a rewrite over 18 months, almost 2 years, to figure out which courses I was going to teach in what order and what the outline was. Because I drew all these out first. And this is year 6. We're finally finishing the 200 hours. Okay? But we put migraines at the very bottom and headaches because you have to have all these, skills of these other things to get there to do it. And also one of the advantages of when you're learning functional medicine, if you have the same person teaching you all the connections, the concepts, they can make all the connections for you, which can let you see the bigger picture, which is really one of the important skills. Now, remember with migraine, the greater skills you have with dampening vascular inflammation or neuroinflammation or fixing the gut or balancing hormones is only going to be an attribute that'll make you more successful with unwinding that migraine web. And ultimately, the goal is to make them not as chronic because these things lead to brain injury. And you want to make sure your patients don't end up with lots of white matter hyperintensities and then end up with white matter lesions that then lead to dementia and Alzheimer's disease. Okay. Those are the things I want to share with you for this section on migraines. Hope that's useful. Thank you for your time.